It's 12:05, so I think we can start the meeting. So good morning / good afternoon to everyone here. Welcome to today's session of the Teletrauma Grand Rounds. So today we have Dr. Shnaydman and Dr. Lahamm Andraos presenting a case from Westchester Medical Center, New York, and it's titled Surgical Stabilization of Rib Fractures in the Geriatric Patient. So over to you both to start the case presentation.
Good morning, everyone. My name is Rebecca Lahamm. I'm one of the Trauma Surgical Critical Care Fellows at Westchester Medical Center in Valhalla, New York. I am originally from Beirut, Lebanon. I did my medical school and finished my general surgery residency at the American University of Beirut in Lebanon and joined Westchester in July. I'll be discussing surgical stabilization of rib fractures today. I'm going to be going over 3 cases that we recently operated on, and then go over some points on rib fixation. I'll be asking your help in brainstorming next steps in our patients' cases, trying to make this as interactive as possible. And of course, please feel free to interrupt me at any point for questions, comments, and sharing ideas. Dr. Kirsch and Dr. Shnaydman have been involved in the care of these patients and helped me put this presentation together. I have no disclosures. Objectives of this talk is going to be relevant anatomy of rib fractures, technique and options for operative management, and injury mechanism associated with injuries and risk factors and rib fixation. The first case is an 88-year-old lady who presented to Westchester Medical Center as a level 1 trauma after a motor vehicle crash. Her husband was driving. She was a restrained passenger. Her husband had a cardiac event and drove into a pole. They were deployed, and she had a prolonged extrication of 35 minutes. On arrival to our ED, she had airway. She had decreased breath sounds bilaterally and chest tenderness and bruising with a palpable rib deformity with O2 saturation of 90% on 15-liter non-rebreather. She was hemodynamically normal, heart rate was in the 80s, GCS 15. She had an obvious internal rotation with closed femur deformity on the right, and a knee immobilizer was applied. Exposure was obtained. Her FAST was negative, and for completion, her past medical history includes hypertension, hyperlipidemia, GERD, and hypothyroidism. She is basically a very functional lady. She takes care of a couple of her children that have special needs. Her X-ray in the trauma bay looked as such. I hope it's projecting well. I'm not sure if you can see, she has bilateral rib fractures with the right apical pneumothorax, no tension pneumo, not on X-ray, not physiologically. So with this presentation, what would be your next step for this patient?
Thank you, Dr. Lahamm. Dr. Andraos, would you like to make the comments first?
In this case, it looks like the injuries are limited to the chest, the right chest. I'm having trouble seeing the rib fractures and the pneumothorax. It's really, yeah, I can imagine it based on your representation. But otherwise the chest X-ray looks reasonable. And then she has the fracture of the leg. If it's the femur or a posterior, perhaps a posterior dislocation of the hip, I'm not quite sure. I would certainly have X-rays of that, and you've got a CT scan is fine in this case, and she's stable. And I would manage the biggest risk to the patient is the chest wall injury. That looks like a 15%, 20% pneumothorax. I would put a chest tube on that side, and then study those images, the rib fractures, to see if there's a flail or how extensive the injury is.
So this is for more details, her CT scan. The pneumothorax is more obvious on her CT scan, and you can also appreciate a sternal fracture with some peristernal small hematoma that is luckily not compressing the heart. And this is her 3D reconstruction with her rib fractures. As you mentioned, pigtail would be good idea in this patient, but what about her oxygen requirement and her being on a non-rebreather 15 liters with 90% saturation? What are your thoughts on intubating this patient?
Thank you, Dr. Lahamm. Dr. Frisbee, do you have any comments?
Yeah, that's a pretty good question. A non-rebreather, and she's working hard, I'm sure. Well, sooner or later she's going to poop out, and she's going to lose all of her reserve. So it might not be a bad idea to talk to her and tell her what you're going to do, and give her a chance to rest. In the meantime, if you can do that, you can go ahead and study these this minimal sternal fracture and these rib fractures, and just see whether or not you do have a flail. I don't think so, but that's what I would do.
Thank you, Dr. Frisbee. Dr. Fraga, do you have any comments?
And I think it's important a good analgesia for the patients. And it's a small pneumothorax. You need to observe this patient at ICU, but I think it's safer to put a chest tube. It's not so small, the pneumothorax. And you need to talk with the orthopedist about the stabilization of the fracture on the femur. It's a surgical case, and about the chest. Probably just wait. Usually my hospital don't indicate surgical treatment for hip fracture. So just analgesia and keep the patient oxygen. It just excludes associated injury in the abdomen. It's very important too. Thank you.
Thank you, Dr. Fraga. Dr. Kasim, do you have any comments? We cannot hear you, Dr. Kasim. I can hear you.
I would start from the beginning, BAC, and make sure she's not bleeding anywhere. But you're going to appreciate that she's going to have some blood loss from the fractured femur. You could lose as much as 1.5 liters of blood. And she's elderly, and she sustained severe injury to her chest. And also on the left, there was some question about the left knee injury. Make sure that has not compromised the popliteal artery by any chance. So having ruled out other injury, she's fairly stable at this moment. So the question is, what do you do with this rib fractures and the sternal fracture? The sternal fracture is non-displaced, so I would leave it alone for the time being. And pneumothorax need to be decompressed, and I don't like pigtails because they get clogged up very quickly. I prefer to put a chest tube in. And if she's very stable and like she is, I would do the same thing like you have done, get a CT scan, and then get my radiologist to reconstruct the chest wall to see where the fractures are. If it looks like it is anterior rib fractures, and they are numerous, and these do cause respiratory embarrassment, and the patient very soon will become tired of breathing, and the splinting from the pain itself will have some effect on the oxygen delivery and oxygen saturation. So having ruled out all the other stuff, then you need to make a decision whether you want to intubate this patient. In my opinion, I think this patient does deserve intubation because she is going to be pooping out pretty quick. And also management of fluid is very, very important because underneath that rib fracture is a contused lung, and contused lungs seem to hold on to fluid much longer, causing pulmonary edema. We were aware of that too. I'll stop there. Thank you.
Thank you, Dr. Kasim. Dr. Hodgman, would you like to?
Well, our approach will be a little bit different. We tend to, this patient needs to be intubated. If you look at the 3D recons, she has bilateral rib fractures in the left side of the anterior. In the left side are lateral. This creates essentially an unstable chest plus external fracture. So this, we always talk about the flare chest when you have the fracture rib in two places, but bilateral rib fractures anteriorly act as an unstable chest, particularly with external fracture. So this patient needs to be intubated in the ED. We need the chest tube because he has a pneumothorax, and now we are doing positive pressure ventilation. We'll have undergone a pan CT scan, make sure it doesn't have other injuries. I assuming based on these pictures that the only injuries are the rib fractures and the femur, the periprosthetic femur fracture. They're both very bad injuries in a patient like this. The fluid loss, the blood loss around the periprosthetic femur fracture is expected to be high, so she would need resuscitation. So this patient needs to be resuscitated, need to be intubated, be in the ICU, resuscitated, make sure there is no other injuries. And after that will be the timing of the rib plating. If the ribs are the only injury, we will usually proceed with surgery within the first 24 hours. That has, in general, we try to do the surgery the first 3 days if possible. This patient probably can be done in the supine position. I'm not sure, and I really need to see the more images to make sure that the right side of rib fractures are accessible from the front. Maybe we need to do the left ribs, and after that, put the patient in a right lateral position. This patient with the femur fracture, probably the femur fracture will be done first. And as soon as this patient recovers from that, probably the next day, we will do the rib plating. That will be our approach. One of my partners who is present in this meeting, she did recently a review of our cases of 380 cases. And this is the reason that we go this way. Thank you.
Thank you, Dr. Hodgman. Dr. Lautenberg, would you like to make any comments?
Yeah, I agree with Dr. Hodgman, basically. I think this periprosthetic femur fracture is going to be really difficult, but it's got to be done, obviously. My only question is, what kind of analgesia would you provide the patient after intubation? I think this patient would be a good patient for a low dose ketamine drip for pain. The other thing you could consider is a thoracic epidural, although I couldn't tell whether there were any vertebral fractures to try and help the patient's pain. But I would also try and get this patient to the OR for plating. I would do it supine. I could approach both sides of the chest and even get further lateral with bilateral inframammary type incisions. And then I'd make a determination on the sternum as well. It wouldn't be a big deal to place 2 vertical sternal plates on that sternum. And the only thing that we don't know, and you won't know till you get in there, are there any cartilaginous injuries that have dislocated the sternum from the chest wall. But I totally agree with Dr. Hodgman.
Thank you, Dr. Lautenberg. Back to Dr. Lam to continue.
Thank you for all these extensive and very valuable comments. The patient was actually pan-scanned and her injuries are listed here. She had bilateral pneumothorax, pneumomediastinum. She had pulmonary contusion with airspace displaced sternal fracture with superficial and deep hematomas, displaced rib fractures on the right 1 to 11th and on the left 3 to 7. The left was more deformed than the right chest. She had an L4 TP fracture, non-op, and a displaced periprosthetic right femoral fracture, non-displaced fracture of the right patella that was also non-op. She had palpable pulses all along her right lower extremity, and her compartments were soft. This patient was indeed, right pigtail was inserted and she was indeed intubated in the ED, especially with her ABGs coming back acidotic, suspected most probably the loss of volume from her periprostatic fracture. She was resuscitated with blood, FFPs, crystalloids. She was transferred to the ICU, and after proper resuscitation, her hemodynamics were normalized, and her metabolic acidosis was resolved. And slowly, progressively, she was weaned off pressors, and that was day 1 of the trauma. Now, I know we touched upon this, rib plating, sternal plating, one side, two side. Should we do the femur fracture first, the chest first? What are your thoughts?
Thank you, Dr. Lam. Dr. Kasim, do you want to make your comment?
Well, ideally, the femur fracture should be fixed first. Usually, that has been the kind of a protocol. You give 24 to 48 hours for the chest problem to stabilize. Did you give this patient 5 liters of PEC cells?
We did. She was hemodynamically unstable in the trauma bay, and she was with her acidosis and her on the ABGs, her hemoglobin had dropped with 3 units. So we resuscitated her with blood, specifically that she's a trauma patient, and she was responding very well until she went off pressors and her hemodynamics normalized and her acidosis resolved.
Right. That's a lot of blood. Of course, you know, if he needs it, she needs it. To get back to the question again, the way I would go about would be have my orthopedic surgeon get involved as early as possible and see if he would like to tackle the hip fracture first. And then subsequently, when he's done with it, very soon, I may elect to go ahead and fix the left side first. I'm not sure whether I would be inclined to doing the right side first. The left side is a lateral fractures, and they look pretty stable to me. And I think I would just do the left side first, and then wait to see what happens, how she progresses as far as the left rib fracture are concerned. Pain control and the liposomal acetaminophen IV seems to work very well for these patients, and along with the intercostal block, and also they have a special catheters available that you can put anteriorly and posteriorly in the operating room and infuse pain medication through that. And of course, some surgeons who have been used to doing a thoracic epidural, they are still using it. I think we have moved on to using the other modality that I've mentioned. Thank you.
Thank you, Dr. Kasim. Dr. Andraos, do you have any comments?
Yeah, so I basically agree with all the other comments. Looks like she's been intubated, stabilized, the acidosis is resolved. And I would certainly bring the orthopedist in, consult the orthopedist early and get their opinion about the management of the right femur fracture and the right patella fracture. And looking at the chest x-ray, it looks like she does not have, first day, any evidence of a pulmonary contusion. And I gather she's oxygenating well. The report on the CT said that there's more deformity on the left, but do you recall before she was intubated, did she have a visible flail on either side? On the right side, there's costochondral separation up and down the chest. And I guess that's what they mean by the fractures 1 through 11 on the right. And I just saw 2 or 3 posterior fractures. So I can't really tell how much of a functional or an anatomic flail she would have. And as far as a functional flail, you probably could have judged that initially, but I think regardless, in an 88-year-old woman with all those rib fractures and her initial destabilization and hypoxia, it's reasonable to plate the ribs. And I would just do, if the right side had a visible flail, I might consider that side first. If the left side's, if the left side's more deformed, the other side first. But I imagine you plate both sides in this case. But it looks like the femur fracture would be the first priority after you've stabilized her respiratory system.
Thank you, Dr. Andraos. So in the interest of time, does any of the panelists have any comments, or otherwise I'm going to give it back to Dr. Lahamm to continue. Okay, back to Dr. Lahamm. You want to continue?
Thank you. Orthopedics were consulted, but their repair for the femur fracture was delayed for another day. So we went ahead and took the patient down for rib fixation. On her initial presentation, the big deformity on her chest was actually on the left side with a visible flake more than the right. So the decision was to plate the left side with the sternum because of the displaced sternal fracture and the big deformity that was clinically seen. During the case, some of her ribs were extremely thin and friable to the extent that the screws that needed to be put for fixation of the plate were longer than the thickness of the bone. So if you can see, there's some spots where we have like a suture cerclage around the plate just to make sure that they stabilized enough, because the screws were longer than the thickness of her bone. So her rib fractures on the left and the sternum were plated, and a chest tube was inserted, and she was transferred back to the ICU. Fortunately, she was still on low ventilatory settings, and she was oxygenating and ventilating well, and she was hemodynamically normal at that point off pressors. So day 2 after the trauma, she was plated. Pain catheters were inserted. I believe they were paravertebral pain catheters. They were inserted in the OR while the plating was done. The only reason she was kept intubated is because her level of consciousness was not enough for her to protect her airway, but otherwise, pulmonary-wise, she had no concerns. The pneumothorax were drained, she was plated, and she was on minimal settings. The day after, she was taken to the OR for open reduction internal fixation of her periprostatic femur fracture. Unfortunately, after she came back from that procedure, she had increasing creatinine, worsening kidney function, and increasing CK. This was the evolution of her chest x-ray, day 1, day 2 after plating, day 3 when she went to the OR with the ortho team. I have mentioned she failed to be extubated because of her mental status. However, meanwhile, the next day she has increased subcutaneous emphysema with increasing air leak in her chest tubes. And we have repeated a CT scan that showed persistent and increased pneumothorax. So the right pigtail was upgraded to a chest tube in order to try to control this pneumothorax. Her kidney function was still worsening. And because of the persistent air leak, the interventional pulmonary did a flexible bronchoscope and try to quantify any injury that can be controlled with a valve. They tried to place a left upper lobe valves, but unfortunately the patient did not tolerate them. She was hypotensive, tachypneic, hypoxic, so the valves were directly removed. And throughout this course, she had worsening of her P-to-F ratio, oxygenation, and increase in her subcutaneous emphysema and pneumothorax. So in this setting of worsening lung status, oxygenation, and persistent pneumothorax with an extensive sub-Q emphysema, what are the thoughts on the next step?
Thank you, Dr. Lam. Dr. Frisbee, do you have any comments?
What'd you find on bronchoscopy?
She had a kind of 70% air leak in the left upper lobe that could not be controlled with the valve because the patient could not tolerate it hemodynamically.
Gonna have to close that bronchus. I don't have anything to add. Not now.
Thank you, Dr. Frisbee. Dr. Hodgman, do you have any comments?
Well, just a few things. One thing is that these patients, 88, they have very brittle bones. And that's the problem. And that's the reason many times we try to avoid surgery. But in this case, unfortunately, you don't have the choice. You have to operate. But what you found that having problems with the screws holding the plates is a very common problem. I'm not sure I would put longer screws because I'm afraid that this might be part of the problem, causing the problem. Many times, almost all the time now, we usually at the same time we put the, particularly so many rib fractures, and if you have a pneumothorax or a hemothorax, we put a camera there to see what's going on and clean the pleural cavity. Unrelated to this, I will probably have fixed the femur fracture sooner, and many of my colleagues here mentioned that, because long bone fractures has been a big difference in the last 30 years, fixing long bone fractures early rather than late. And many of the pulmonary complications, for example, fat embolism or the classical fat embolism almost disappear after the early fixation of the long bone fractures. So I'm surprised that they did that 4 days later. I would have the orthopedic surgeons bugging me here in like in 2 hours. When can I go? When can I go? The other thing, the DVT prophylaxis, unless the patient is actively bleeding, we start the first 12, 24 hours. And I'm not sure that the endobronchial valve will work in a case like this. Looking the way this looks, you have a massive air leak. If you cannot control it with the chest tubes, you probably have to go and explore and maybe staple the lung, because probably this is a big laceration in the lung. I will put bilateral chest tubes, put it on suction, it happen, but if it cannot be controlled, you probably have to go with surgery. Thank you.
Thank you, Dr. Hodgman. Back to you, Dr. Lam, to continue.
We kind of elected to go on with the ARDS rescue therapies at this point where she had worsening patchy infiltrates and oxygenation. Ongoing discussions with the family were obviously going on every single update with the patient. She was put on DNR that day, and she still had worsening kidney function with increasing pressure requirement, and she was started on CVVHD. Left anterior chest tube was placed to try to control the pneumothorax, and Gill's procedure was done over the left chest, and VAC on suction was put to try to decrease this subacute emphysema. All the chest tubes were on suction, and another anterior chest tube was placed. So now she had 2 chest tubes on both sides on suction with the Gill's procedure. A TTE was not possible due to the massive subcutaneous emphysema, so we could not have any proper windows to assess. So a TEE was done, and it showed an element of pulmonary hypertension. So the patient was started on nitric oxide. She was sedated, paralyzed, and proned. And actually, after all those intervention, her airleak was more controlled, and her P2F ratio started to improve again. However, at that point, she was found to have serratia bacteremia, most probably suspected from the lungs, and she was in a worsening clinical status. She was in multi-organ dysfunction, and the family elected to transition to comfort measures, and unfortunately the patient passed away. For the sake of time, I'm gonna move on to the second and third case. The second case is a 91-year-old man who presented as level 1 trauma after a fall down a flight of stairs. He fell 6 steps, and he had positive loss of consciousness. On presentation, he had intact airway, decreased breath sounds on the left with a visible flayed chest. He was hemodynamically normal with a heart rate of 88. He was a GCS of 14, a bit confused, and exposure was obtained. FAST was negative. For completion, his past medical histories: hypertension, prostate cancer, status was prostatectomy, baseline functional, 91-year-old. This was his imaging on secondary survey. You can see the massive pneumothorax with a chest wall deformity on the scan. With, I'm not sure if they're visible on these cuts, with rib fractures. Again, the chest wall deformity. And this was the 3D reconstruction with left displaced rib fractures and a chest wall defect. This patient was taken for rib plating, but my question for the audience is, how would you approach the rib fractures that are very close to the costochondral junction, and what would be your plan on the loss of chest wall, like the defect in the chest wall?
Thank you, Dr. Lahamm. Dr. Fraga?
Just to clarify, this patient had fractures across multiple of the costochondral junctions, as well as having a large wall, chest wall deformity with the intercostals being just blown apart. So that's the question.
Thank you. Dr. Fraga, would you like to hear?
No comments. No experience with rib fixation here in my hospital. No experience.
Thank you, Dr. Fraga. Dr. Laudenberg, would you like to make any comments?
Yeah, but both of these cases are good examples of your hands are kind of forced. This one, you're forced to do something because if you leave this patient with this defect, he's going to have a massive lung herniation once you re-expand his chest and take care of the pneumo. So you got to fix it. The question of costochondral involvement, you need a long plate. You need to come across the sternum, probably fixate through to the sternum and even to the opposite bony rib. As far as the defect goes, you need to put something between the lung and the chest wall. You could use a biologic, you could use a synthetic, but you need to you need to put something in there.
Keep your head still, sir.
Tough case. But I think you need to fix this. And I'd like to know a little bit more about pre-op workup, lab work and cardiac function and things like that, but this is, your hand is totally forced here because you're going to wind up in an impossible situation.
Dr. Lahamm, Dr. Armstrong, do you have any?
Yes, so you say that the patient is flailing on the left side and the underlying lung, it's hard to evaluate on the CT with the pneumothorax, but I agree with Dr. Lautenberg that you'd have to repair the two fractures, that's the flail, with the soft tissue loss in between, and as far as for repair of the chest wall defect, you can start simply just with mesh. You can put Prolene mesh outside extrapleurally deep to the ribs, and that would add stability. If there's too much loss of soft muscle, there are more aggressive options, including a latissimus dorsi flap that you or the plastic surgeons can help you with. It would be a relatively small defect, and the flap is nearby. Although in a 91-year-old, want to keep the operation as simple as possible. So I would favor the first option, to plate those two ribs, see if you can repair the defect with mesh, and then avoid having to carry out a the latissimus dorsi flap. But at least in this case, the trauma is limited to the chest wall, and there's no femur fracture. I think his prognosis is probably a little better than that of the first patient.
Thank you, Dr. Armstrong. Does any of the panelists have any other comments? Otherwise, back to Dr. Lahamm to continue.
Could I make a comment?
Of course, Dr. Kazim.
Well, Dr. Hodgman makes a very good case in these two cases. You have to tailor-make what type of plating, screw, clamps, etc. you're going to use in trying to achieve what you're trying to achieve in stabilizing the chest wall. In elderly patient, the ribs are inevitably thin, and there is not a lot of bone tissue available for you to put tight screws, long screws in there. It will fail. And therefore, the other alternative for these will be the clamp tap techniques. Those are available. I think you should have both, screws as well as the clamp tap technique to be deployed in the eventuality of the ribs being so thin. The second case that we are looking at is it is much more extensive in the destruction than the first case. And therefore, you may have to deploy tailor-made equipments to be able to stabilize the chest. And as Dr. Untrak mentions, you do not only have to stabilize the rib with whatever means that you want to use, and you may have to cover the tissue loss. And the simplest way that would be to use some type of patch material instead of doing a big surgery like latissimus dorsi flap, etc. In a 91-year-old man, I think that'll be too much surgery.
Thank you, Dr. Kazim. Dr. Lahamm, back to you to continue.
Thank you. This is how severe his main chest was.
Keep your head still.
Just for illustration. So he was taken to the OR, and the approach was an inframammary incision with subpectoral dissection to plate those ribs, especially the multiple. It was challenging because of the multiple rib fractures close to the costochondral area, and the chest wall defect that had the obviously lung protruding from it was patched with a mesh, and the chest was closed.
So in this case, when we fixated his ribs, we actually went over the costochondral junction onto the sternum because you cannot put screws into the costochondral junction. So in order to stabilize the fracture, we played it onto his sternum.
So you can see on the x-ray how it overlaps with like all over the rib to the sternum in order to fix the chest wall. And this is his post-op x-ray. The patient actually did great. He was transferred out of the ICU on post-op day 3 and transferred to rehab on post-op day 7 with no supplemental oxygen. Our third case is a 78-year-old lady that presented as a level 2 trauma after fall down 3 steps, and she landed on her right side. On presentation, she had intact airway, she had decreased breath sounds on the right side with splinting and saturation of 95% on 4 liters nasal cannula. She was hemodynamically normal, GCS of 15, exposure was obtained. Her FAST was negative. She had a history of diabetes, hypertension, hyperlipidemia, obesity, osteoarthritis, and obstructive sleep apnea, which increased her risks for respiratory complication. Her injuries were right 5 to 10 rib fractures with hemopneumothorax, right perionephric hematoma, and right distal radius fracture. This was her scan. You can appreciate the chest wall deformity on the right and the moderate hemothorax on the right. And this was her 3D reconstruction with her fractures from the 5th to the 10th rib. A 14 French chest tube was placed, a pigtail, sorry, was placed on the right side, and it drained 700 of sanguineous output. The lung expanded on the x-ray after the chest tube insertion. She had a multimodal analgesia and pain management. She had perivertebral pain catheter placed, but the pain persisted and she had increased O2 requirement. She was eventually on high flow nasal cannula that we couldn't wean, and her lung collapsed and she had a retained hemothorax on the chest x-ray. So we elected to take her to the operating room for rib plating, and the decision was to have a intrathoracic plating since we needed to have a VATS for her to evacuate the hematoma, the retained hematoma. So we had an intrathoracic of her 5th, 6th, 7th, and 8th rib. This is her x-ray post-op. I hope you can see the plates on the lateral right chest wall, and she had 2 chest tubes inserted. Eventually, she also was transferred to the floor, and the chest tubes were progressively removed, and she was prepped to go to rehab. Any comments or ideas before I go through rib fixation and rib stabilization management?
Thank you, Dr. Lahamm.
So did you learn the lesson not to put a pigtail in a patient who is a pneumothorax? Very provocative, sorry.
That's okay.
I think Dr. Untracht had a comment, right?
Yes, Dr.
Well, yeah, it's the same comment. Dr. George also mentioned it in the chat, but after you put the pigtail, did it drain the hemothorax and expand the lung? If it totally evacuated the hemothorax and expanded the lung, okay, but certainly in retrospect, knowing what happened, it's easy to say, okay, you should have put the proper chest tube. But did the pigtail actually evacuate all the blood and expand the lung?
It did actually drain 700 of sanguineous discharge, and the post-insertion X-ray was expansion of the lung. I wouldn't say 100%, but almost 95%.
Yeah, and that may have had nothing to do with the course, and the patient did well anyway. You're able to take care of the problem. So I wouldn't be, it's easy in retrospect, but I still would have been inclined to prefer, for blood in the chest and trauma patients, I would be inclined to put a chest tube. But I think it was probably reasonable that you did anyway. But not nice results with certainly the last two patients, and the first patient, would have been a miracle if she would have survived that with that big femur fracture. Probably the car was going faster than relatively fast to get that degree of injury.
Thank you, Dr. Andrack. Dr. Hodgman, you want to make a comment?
Just two quick comments. One is, we used to say, do not call a child to do a man's job. Now we say to do an adult person job. But don't call IR to do the surgeon job. That's what happens. So that's supporting what Dr. Kasim was saying. One thing, this patient had essentially, I could see in some of the CT scans, she has posterior rib fractures very close to the spine. Those cannot be plated usually, it's very difficult. That was when the internal plating, the one that you did came in just to try to fix those very posterior. However, I would argue what you did is plenty, because by fixing the lateral fractures, you remove the component of flailed chest from there. So you created just simple rib fractures posterior, which are usually relatively well tolerated because the paraspinal muscles stabilize those ribs. But what seems that we've been doing lately, we just did very few cases, but really with very good results, is to do a paraspinal block with an on-cue pump, and the patient can go home with the on-cue pump. And that really works very well. One of my partners also has been using, when he goes inside the chest, is essentially a probe that freezes the intercostal nerve, and that controls the pain for a few weeks or months, and with also very good results. I have no experience with this. One of my partners is using it, but he seems very happy, and we probably will move to that technique in order to control postoperative pain, particularly that the ribs that we couldn't fix. Thank you.
Thank you, Dr. Hodgman. Dr. Frisbee, do you have any final comments?
Yeah, 2 out of 3 ain't bad. Hoitman is right. 88 years old and fractured femur. The femur is what got her. In my opinion, she got behind the 8 ball when she started to pull all that blood into that femoral space from that fracture. And she got down, and the fact that her ribs are so brittle that they're just not going to hold that fixation very well. And she just went downhill from there. All 3 cases were excellently done. A lot of thought process went into this. I would have gotten the orthopedist on case number 1 probably before before sun went down. So that's the only comment I have. Very nice cases. Thank you.
Thank you, Dr. Frisbee. Dr. Kasim, do you have any final comments?
Dr. Frisbee, as you very well know, you can never tell an orthopedic surgeon what to do and when to do. They have their own time clock working.
No, say it isn't so.
But anyhow, 3 cases. I learned a lot from the management of these complex cases. And I'm glad that you brought it to our attention for the for discussion today. I'm going home much more wiser than I was when I woke up this morning. Thank you for presenting excellent cases, good material, well managed, and lots of learning pearls here. Thank you.
Thank you, Dr. Ghasim. Dr. Lautenberg, any final comments?
Yeah, great tour through geriatric rib fractures. I think there's a decent amount of evidence-based medicine on the fact that you can fix ribs on geriatric patients. And, I think this points it out. I mean, we also see different techniques of doing it, intrathoracic techniques. Just two comments on these brittle ribs. We know they're there. One of my colleagues uses Zip Fix, which is the PEEK material that you can close sternums with around ribs to sort of reinforce it. I sort of use U-plates for these elderly patients because the screw locks to the back of the U-plate. But you have to be careful that you don't put too much tension on the ribs, because I've actually cracked some elderly ribs. But there's a lot of different devices out there that we can call upon to fix these patients. Great presentation. Thank you.
So much, Dr. Lautenberg. Dr. Fraga, do you have any final comments?
Congratulations, excellent case. Congratulations. I learned a lot.
Thank you, Dr. Fraga. Back to you, Dr. Lahamm. You want to continue?
For the sake of time, I'm gonna skip through the basics, just highlight a few of the important things about rib fractures in elderly. They have twice the mortality and morbidity of rib fractures in younger populations, especially in mortality and high risk of pneumonia, which should push us to be a bit more aggressive in the management of these injuries. Systemic multimodal analgesia, regional analgesia, rib fixation, and management of associated injuries such as hemothorax and pneumothorax, tension pneumo, any chest major vessel injury, and blunt aortic and cardiac injury to avoid increasing the mortality and morbidity in this population. Key steps is having a proper imaging and 3D reconstructions, as previously mentioned by most of the panel today. Indication and the characteristics and the patient selection is very important. The surgical approach, depending on the type of injury and the patient's details, and of course the intubation options, single versus double lung, and the post-op wound care and chest tube placement. Indications are flail chest, multiple fractures, fracture leading to penetrating the ribs into the lungs, displaced rib and sternal fractures, uncontrolled pain with failure of medical therapy, and worsening respiratory function. Of course, if the patient is hemodynamically unstable, has a GCS less than 10, has a severe pleural empyema, mediastinitis, and spinal or pelvic fracture, the rib fixation should be avoided or postponed until these problems are solved. Usually it's as soon as we can, so within 3 to 7 days of the injury, and we can do bilateral fixation, as mentioned before, within the same case, or if we want to wait 24 to 48 hours to do the second side, if it's indicated. VATS is also used for control of bleed, evacuation of hematoma, and intrathoracic fixation at the same time. So in case the patient needs a VATS, it would be a good idea to proceed with intrathoracic fixation. There are multiple approaches: anterolateral, posterolateral, subcapsular incisions, and minimally invasive. For the sake of time, I'm just not going to go into the surgical details. There's just this paper that I want to mention about the intrathoracic versus extrathoracic approach, which showed better stability, smaller incision, and less morbidity, but obviously a higher cost. But it's a logical option to use if we need to do another procedure, such as hematoma evacuation in a patient. Last but not least, surgical stabilization and geriatrics have been shown to decrease mortality and get the patients out of the ICU at the expense, obviously, of pneumonia and increased hospital stay that might be due just to survival versus people usually having higher mortality without the rib fracture fixation. Thank you so much. Sorry, I had to go so quickly at the end just for the sake of time. Thanks for all the interventions and comments.
Thank you so much, Dr. Lahamm and Dr. Shnaydman. And thank you for posting a little summary on the chat. If people are interested, it has all the points that we discussed today. Thank you to all the panelists for all your wonderful insights. I hope to see you next time.
Thank you, everyone. We all learned a lot, and this conference is invaluable, and it's always good to see friends. So thank you. Thank you.
Nicely done. Nicely done. Nicely done.